Stress urinary incontinence is the loss of urine in response to sudden increase in intra-abdominal pressure in the absence of detrusor contraction, e.g. sneezing, coughing, laughing, and movements. The prevalence is in the age group between 45 to 55 years. It is a bothersome condition affecting the quality of life. Most common type of urinary incontinence, it ranges between 30 to 55% of patients. The risk factors are age, obesity. The obesity leads to increase in intravesical pressure created by a rising BMI, may reduce the continence gradient between the urethra and the bladder. Family history, history of type of childbirth, surgery, and medication. What maintains continence? There's intrinsic urethral closure mechanisms, and then the supportive extrinsic mechanism, which is the pelvic floor. There's also intact facial and mucosal support, good blood supply, intact nervous system. Disruption of any of those features may result in decrease in functional capacity of the urethra. The exact etiology is unknown and is thought to be multifactorial. It's thought to be multifactorial. There's a number of theories with the Glency-Hammock hypothesis, the integral theory, and the Enhoning PR transition theory. But all these theories suggest a disruption in the supportive connective tissue of the bladder and the proximal urethra, weakening of the pelvic musculature, and reduced urethral pressures. So this is a diagram just showing the pathophysiology of stress urinary incontinence. The pathophysiology ranges from extrinsic mechanism to that of intrinsic sphincter dysfunction, but in the majority there is an element of both. Evaluation before insertion of mid-urethral slings. We need a detailed history on fluid intake patterns, medical and surgical history with particular attention to any history of urinary tract infections, diabetes, urological surgery, obstetric trauma, pelvic radiation, and central nervous system or spinal cord disorders. We also check the menopausal status of or presence of hypoestrogenism. We check if patient has nocturia, psychological stress, and we also check on the type of protective products the patients use, such as tampons, pads, or diapers, and the number used daily, and the void patterns. And then we do a physical examination. On physical examination, we do a general exam of the patient, and then we do our pelvic examination. Our pelvic examination should be conducted with the patient both standing and supine, and with a full and empty bladder. Observations of involuntary leakage from the urethra, synchronized with exertion or effort, or on sneezing or coughing. And then we also do an assessment of the urethral hypermobility by using a Q-tip test. And then we measure the post-void residual volume. And we must not forget to do a urinalysis to rule out urinary tract infections. The management of stress urinary incontinence involved surgical and non-surgical management. The non-surgical management, we need to motivate our patients to have a lifestyle modification where they...
I will leave it like that.
Incontinence. The medication is called duloxetine. This medication is associated with the reuptake inhibition of serotonin and norepinephrine at the pudendal layer. It can increase the activity of the external urethral sphincter and can significantly reduce stress incontinence episode in up to 64% of patients. However, it is not commonly used and it works for minimal stress urinary incontinence, and its side effect profile is not easily tolerated by our patients. For the elderly patients with genital syndrome of menopause, Premarin cream is used. We're going to go through the history of the different type of surgeries that have been happening over the past century. So from 1970, there was an early autologous slings were introduced. They initially started using the gracilis muscle to encircle the urethra. Then they moved on in 1910, where they're still using the early autologous slings. They used the pyramidal muscles to create the sling. And then in 1912, Kelly's applications were developed. In 1917, bladder, neck, and sling placed transvaginally were done. By 1930, early autologous slings or Kelly applications were the common surgeries. And then by 1934, there were theories about stress urinary incontinence was based on radiographic findings. There were two theories that were developed then. And then in 1942, rectus fascia with the muscle was used as part of the management of stress urinary incontinence. Between 1940 and 1960, urethroplexy, the Marshall maturity creds and batch suspensions were introduced. In 1970, they started defining stress urinary incontinence differently, and then in 1978 we started using. We had a high success rate from the autologous PVSs, and then by 1990, modern PVS and true urethroplexys were developed, and then by 1996, the PVS and the mid-uretral slings, that's when the TVT was developed. In 2001, the transobturator was developed. And then by 2008 to 2001, FDA started having issues about mid-uretral slings. We'll go through that as the presentation continues. And then between 2014 to 2016, different bodies also had statements regarding slings. By 2017, the different bodies had guidelines on management of stress urinary incontinence. We'll discuss that as the presentation continues. So these are between 1909 and 1996, the different surgical procedures that were done. So the surgical treatment of stress urinary incontinence incorporates more than 110 operations from the early 19th century. From the 1960s, surgery commonly performed was birch corpus suspensions preferred by gynae and the sling procedures by the urologist. The latter procedure was associated with high degree of morbidity and avoiding dysfunction post-surgery. Urethral bulking had a role, and the artificial sphincter was offered when patients fail from all surgical options. So this is a trend of the different type of surgeries over the years. You can see that from the year 2000 until 2009, you can see an increase in the sling usage compared to the watch, which had from early 2000s till 2009, the rate of using the thing had decreased. So annual rates of different types of stress urinary incontinence surgery for each year from 2000 to 2009, there was a significant increase in the total stress urinary incontinence procedures over the years. There was also a significant increase of slings over calendar time. For all remaining procedures, there was a significant decrease over. There was a significant decrease for slings over calendar time. For all remaining procedures, there was a significant decrease over calendar time. Birch collagen injections, laparoscopic stress urinary incontinence procedures, transvaginal hysteroscopy, hysterectomy with corpourethrocystopexy, needle suspension, and calcification. Rapid adoption of the mid-uretral slings after its introduction in 1996. It became the most popular surgery for stress urinary incontinence around 2005, as you can see from our graph. So the type of meshes that are found, there are 4 different types, but type 1 mesh has the highest biocompatibility with the least propensity for infection. It is microporous mesh. The pore size in excess of 75 nanometers, easily allows macrophages, leukocytes, fibroblasts, blood vessels, and collagen to transverse the pores. Thus, microporous meshes promote tissue host growth with resultant compatibility, and low risk of infection. So we're gonna go through the type of tapes that we use. Tension-free vaginal tapes were introduced by Almeston in 1995. It revolutionized, it's a revolutionary change in stress urinary incontinence management. It's indicated for intrinsic sphincter deficiency and urethral hypermobility. It is safe, effective, and economical. With urethral pubic slings, there's it's a minimally invasive procedure. It's simple. We can use local anesthesia. It's a day procedure. There's mobility. It's safe and effective. This is an image of me leading travel to pubic sling. You can see that the sling just goes into the urethra and comes out of the thing. I'm just going to briefly explain how the procedure is done. So the patient has to be in the lithotomy position. We need to palpate for the pubic symphysis. We identify and mark the midline. 2 centimeters from the 2.5 centimeters from the midline. We mark bilateral 2 centimeters from the midline. And then a 1.5 to 2 centimeter vertical incision on the anterior vaginal wall behind the mid-urethral opening is made, and the dissection is made into the para-urethral fascia. A guide is inserted into the urethral catheter to direct the urethra and the bladder away from the path of the trachea. So if you are working on the right, you need to direct the urethra to your left. And then the trachea is introduced and directed upwards and outwards the pubic bone. Cystoscopy is performed after the procedure on each side. Inspection of the vagina for injuries has to be done. Slings arms are then pulled through the incisions of the So mid-urethral slings, there was a 3-year and a 5-year and a 7-year follow-up of 90 patients. Out of the patients that were followed up in 1999, there were 97 of them that were cured. Out of the 90 that were followed up in 2001, 95 were also cured. And then 7 years later, there was 81 of the 90 that were cured. So these are the different type of slings that are available in the market. So comparison between the TVT and corpus suspension in primary stress urinary incontinence, a prospective randomized multi-center study was done. This was published in the American Journal of Obstetrics in 2004. So there were total, the follow-up was in 2 years, and there were a total of 344 patients. Comparing the TVT and corpus suspension, patients with done TVT were 175 and 169 with done corpus suspension. Cured were 65 under the TVT and 51% under the corpus suspension. There were significantly more cystocells after TVTs and significantly more enterocells after corpus suspension. Bladder injuries were more common after TVT. Longer voiding and recovery time with was found. TVT remained an evidence. TVT reviewed an evidence-based review from inception to current status. Pregnancy, TVT had remained successful after elective seizures. In the elderly, it was well tolerated and a safe option. In the obese, we should be approached with caution. Quality of life, it might be difficult to tease out the impact of urinary incontinence from that of surgery. In conjunction with prolapse repair, assessment of consensus is lacking. Good results for overt stress urinary incontinence, excellent in preventing occult stress urinary incontinence. So these were the complications that were associated with the TVTs. So we have 2 different studies and a complaint reporting statement. So you can see that from bladder perforations, there were none reported with the study done in 2021. There were 4% in 2002. There were none reported from the complaint reporting. Major vessel injury, major vascular injury, there was 0.8% from the study done in 2021. And then the 2002, there was 0.07%. There were 49 cases reported. Vaginal healing defects, there was none reported in the study done in 2001. In 2002, there was 0.7%. Then there was none reported on the complaint report statement. Nerve injuries, there were 0 in 2001. 2002, there was 0.07%. There were 7 cases reported on the complaint side. Tape division or displacement for retention, there was 1%, 2001, 0.2% in 2002. Note, there were none reported under the complaint. Bowel perforation, there was 0.026%. And in 2001, in 2002, there was 0. There were 35 cases, which was 0.05%. Urethral erosion, 0, there was 0. And then there was 0 in 2002. There were 30 cases that the complaint. UTIs reported in 2001, there were 17%. In 2002, there were 14.1%. There was none reported under the complaint. De novo, the true self activity, there was none reported in 2001. And then in 2002, there was 1%, and there was none reported on the complaint statement. Voiding difficulty, it was only reported in the 2002 study. So these are some images of different injuries that we see. So the first image is the trocar going through the bladder. And then the second image is the mesh that is implanted into the bladder. It's a cystoscope. So this image is just showing us the proximity of the trachea where it exits in the in the pelvis in relation to major vessels. You can see that the trachea is plus or minus 3.9 centimeters from the inferior epigastric vein and artery and superior epigastric vein and artery. And it's 4.9 centimeters from the external iliac artery and vein, and it's 3.2 centimeters from the obturator artery and vein. So the indications for our transobturator tape, it's for patients who have previous corpus suspensions, symphysial fixation or plating, previous laparotomy or bowel adhesions, absolute requirements for local anesthesia, morbidity obese, primary urinary stress incontinence, and voiding dysfunction. Reasons to consider a TOT approach. It has a shorter operative time, 10 to 15 minutes, easy to perform and teach, less post-operative pain. It avoids the space of radius, no visceral trauma, potential for less irritative voiding symptoms, potential for reduced urinary retention. Cystoscopy is done at physician's discretion. So these are the images of the anatomic position of the tapes in the transobturator. You can see, so there are 2 different types of procedures when you do the transobturator tapes. There's an inside out and an outside in. So this is the image of the outside in route. So the patient has to be in the tummy. I'm just gonna go briefly through how it's done. The patient has to be in the lithotomy position up to 120 degrees of hyperflexion. We insert a urinary catheter for continuous drainage. A 1 to 1.5 centimeter incision below the urethral meatus is made. Sorry, 1 to 1.5 centimeters below the urethral meatus, a 1 to 1.5 to 2 centimeter vertical incision is made. Dissection of the anterior vaginal mucosa, cervical fascia, dissection is continued laterally to the ischiopubis femurs. From the tendinous incision of the abductus longus muscle at the level of the clitoris, a 1 centimeter incision is made. close to the bone. The needle is placed into the incision and passed medially through the obturator membrane, guidance with the opposite hand index finger in the vaginal incision. So this is when you put in your needle outside, and then you guide it with your index finger of the opposite side. So this is done both left and right of the patient. And then the tape is pulled through the opening that was made below the urethral uterus. This is an image of the obturator artery in relation to the where the trachea actually passes by. This is the inside-in procedure. So the patient has to be in the lithotomy position. We also insert the urinary catheter for continuous drainage. A 2 centimeter vaginal incision on the anterior vaginal wall behind the urethral opening. It's done. Similar procedure where you dissect laterally, and then the exit now is where you entered with the inside in. So now you exit the exit. So manufacturers log of complaints over 260,000 procedures by 2002. There were bowel injuries that were 17 with 2 deaths, vascular injuries that were 32, which was 0.012%, 2 deaths, hematoma 17, external iliac artery injury was 5, femoral artery injuries were 3, obturator artery injury was 1, urethral perforations were 18, which was 0.007%. In 2004, Delors et al. Developed to avoid TVT complications. 32 out of 50 patients with 17 months follow-up between May 2002, February 2002. The mean age was 64 years, 90.6% were cured. Operation time was 15 minutes. Adverse effects were 1 urinary retention in 4 weeks and 5 transient bladder outlet obstructions. And then 6% de novo urinary incontinence reported. It avoids the bladder, bowel, and vascular injury. So the outside-in procedure by NICE guidelines, a meta-analysis was done. Total of 140 patients. The efficacy, the cure was 82 to 96%. Improvement was reported between 89 to 100%. So these are different authors that compared their difficult procedure effects like bladder injury, erosions, and vaginal abscess between 2003 and 2005. You can see that there was only a few bladder injuries. One author reported 1.5 out of the 183 people studied. One reported 5.8% of bladder injuries from the number studied. So erosions of the mesh, and then 1 vaginal abscess. So clinical results from the Lever et al. Study with the TVT, they had a number of 108 patients. They followed them up for 6 months. They had a cure rate at short term at 90.7%, improvement was 3.7%, and they had a failure rate of 5.6%. Intraoperative complications, they had 0. Post-op operation, operative void dysfunction, they had 5.4%. De novo urge incontinence, they had 6.3%. Post-operative healing defect, they had 1%. Post-operative thigh pain, there was only 12%. Anatomical risk for the obturator nerve. So they studied the in and out versus the out and in. There was 27 millimeter difference, and it ranged between 21 to 33% with the out-in, and then with the in-out, there was a 9mm mean, but it ranged between 0 and 12. You can see the mesh, then with the black part, that's where you find the obturator vessels in the nape with the 3 arrows there. In conclusion, with regards to the TOTs, it is safe and effective. It's got specific advantages over TVT in some patients. Further long-term research is still needed with the TOTs. Appropriate training is needed for the surgeon that will be doing the TOT. The surgeon that does the TOT has to do a personal audit. National morbidity register is needed for TOT. I'm going to just go through single incision mini slings. They are not one of the commonly used ones. The procedure for them is the sling is inserted through a single vaginal incision without the need for external incision in the abdomen or groin. It is placed under the urethra and anchored using specially designed self-fixating tips. Advantages: shorter surgery time, reduced pain, faster recovery, and minimal scarring compared to traditional slings. Efficacy studies suggest it is effective, though long-term results may vary. It is typically recommended for mild to moderate stress urinary incontinence cases. The risk complications include urinary retention, growing pain, or mesh-related issues, but the risk profile is similar to the other transplant procedures. An alert was out about the meshes over the years. So in 2008, FDA released a public health notification and safety communication following 1,000 transvaginal mesh-related complications into the manufacturer and user experience database. In 2011, an update of this notification strongly cautioned the use of synthetic mesh for pelvic organ prolapse. At the time, a definitive advisory caution regarding the use of synthetic mesh for the treatment of stress urinary incontinence was not issued. Complications from the mesh use in uretrhal tapes attracted considerable attention from the media. Media reports of negative perceptions of the use of mesh in mid-urethral slings caused patients to refuse surgery. The consequence led to response. The Scottish government recommended suspension of all vaginal mesh surgery in 2014. NHS in England announced a national pause for vaginal mesh surgery. Australia, they banned no use of vaginal mesh. These concerns and reports led to reduction in the use of mid-urethral tapes worldwide and a paradigm shift to non-mesh intervention. It is important that we as clinicians be able to offer our patients alternatives to mid-urethral surgery for the treatment of stress urinary incontinence. While doctors were familiar with the distinction between mesh surgery for pelvic organ prolapse and stress urinary incontinence, patients and politicians were not in Scotland. So this is a summary of the ICI recommendations. You can see that our mid-urethral slings had a grade A for an effective and durable option, and they had a grade B in appropriate counseling about that estimate and limited long-term data, and they had a grade AB to surgical technique should be used on surgery experience and judgment. Then the bulking agent had a grade B on the appropriate desiring single double treatment for stress urinary incontinence and women counseling about limited long-term durability. And the autologous fascia had a grade A for surgical options for primary and recurrent female stress urinary incontinence. Scope suspension had grade A in surgical option for primary recurrent stress urinary incontinence, and considering women undergoing concomitant abdominal surgery had a grade B. So you can see that our uretrhal slings, where the grading was high in this particular condition. So this is a statement from South African UroGyn Association on the use of synthetic mesh by Dr. Rafal, the chair. Synthetic slings are an appropriate and acceptable intervention for women with urinary stress incontinence. There's an extensive data that supports the use of synthetic polypropylene suburethral mesh. In fact, the polypropylene mesh for stress urinary incontinence is the most extensively studied anti-incontinence procedure in history. 3-propylene material is safe as a surgical implant. If mid-ureteral tape is not offered as an option in the management of stress urinary incontinence, we may be doing a disservice to women. When surgery is contemplated, a retropubic approach is recommended. The safety and effectiveness of mini slings for stress urinary incontinence has not been adequately demonstrated. Transvaginal mesh slings should not be used for women with urethral diverticular, urethrovaginal fistula, urethral injury, or previous transvaginal mesh complication. A detailed informed consent process should be conducted prior to sling procedures. Alternative surgical procedures for stress urinary incontinence should be made known to the patient with advantages and disadvantages explained before an informed choice is made for synthetic mesh slings. Provide the patient with a brochure of, if available, from the company. It is prudent that the surgeon performing this procedure should be adequately trained in stress urinary incontinence surgery and capable of recognizing, diagnosing, and treating potential mesh-related complications associated with it. Some of these complications from mesh implants may require additional surgery that may not fully correct them. The surgeon must be conversant with cystoscopy, and it is advisable to perform cystoscopy with all sling procedures. It is advisable for the surgeon to keep a registry of mesh implants and complications with stress urinary incontinence surgery. Thank you.
Thank you, Dr. Nkosi, for that overview. Just want to make a few comments. I think, as she has rightly mentioned, if you look at the age, it's in the age group 45 to 54. So these are not old women. So stress urinary incontinence, as compared to overactive bladder, if you look at the epidemiological data, you get two plateaus with overactive bladder, but with stress, it is 45 to 54. That's the age group. Second thing is that we do not know what the exact etiology is, and I always say, if you do not know what the exact etiology is, you'll never know how to treat it. So there are a number of hypotheses which she has mentioned, that of Enhoning theory, that of the hammock hypothesis by Delancey, and the current one is the integral theory on which the mid-urethral tape is based. So if you look at how the integral theory is that if you do a urodynamics and you do a urethral pressure profile, you'll find that the maximum pressure is at the mid-urethra. That is also the anatomical site of the pubourethral ligament. So by placing the mid-urethral tape in that area, you're basically reinforcing the pubourethral ligament. And why it's kept tension-free is that when you cough, you descend the pelvic floor. So you get dynamic kinking. And that's the mechanism as to how it prevents stress urinary incontinence. So it's important to realize that it must be tension-free. The other thing is that if you look at the pathophysiology, it always ranges between intrinsic sphincter deficiency and bladder neck hypermobility. And therefore, your evaluation of your patients, whether you're doing it clinically or by urodynamics, you should try and gauge where this patient has its maximum problems. Is it intrinsic sphincter deficiency or is it bladder neck hypermobility, so that you strategize your surgery to address it? Because the surgical interventions tend to favor more of either bladder neck hypermobility or intrinsic sphincter deficiency. We didn't mention much about urodynamics, but I think it is something that is very topical. most academic centers around the world would do urodynamics before they embark on any surgical intervention with stress urinary incontinence. We do that in our unit. It has come under major review, this issue around urodynamics. So when you look at urodynamics, you can do what is called eyeball urodynamics, or you do computerized urodynamics. Eyeball urodynamics effectively is to see whether the patient is boiling sufficiently well, and you can tell the patient, when you pee into a container and look at the time. So if you pee 200 mils and it was 10 seconds, you take volume over time, and that will give you your average flow rate. So you have a marker. And then at the end of it, you either assess the residual, and that depends if you got ultrasound and know how to use it. It's easy to do that. Otherwise, you put in a Jux catheter to empty that bladder. That will tell you the amount of residue. That's important information that's given to us at the time that we're making decisions. When we do computerized urodynamics, it gives me a lot of information. The important things to me, for one, is that firstly, it confirms the diagnosis. Because what we always say is the bladder is, as I mentioned that previously, is a poor witness. So if you take a history from a patient, what you think classically has stress urinary incontinence, you only correct in about 75%. If you take again and you look at overactive bladder, you only correct in about 60%. So sometimes you can treat them with conservative treatment, physiotherapy, some medication, etc. But once you start deciding to go on to surgery, you've got to be more exact that you're dealing with the correct thing, because surgery is irreversible. Physiotherapy is good. So even if you're treating something wrong, that's good enough. It may have some other benefits on the patient. Where it helps me is what it tells me, firstly, about voiding dysfunction. It tells me about systometric capacity. It tells me whether the bladder is generating pressures at the time they are voiding. That gives me a marker on the reserve of the bladder. It also tells me about the urethral pressure profiles, because it can go towards intrinsic sphincter deficiency if it's less than 20, right? And then I know my surgical approach is going to be completely different. Right? And then also, it may give me whether there is an element of mixed incontinence, which I then know that surgically my outcome is not going to be as good as a patient with pure stress incontinence. Now, this has been addressed in the New England Journal, right, where people looked and did a randomized trial and felt that urodynamics should not be routinely done in all patients, and I agree on that. Classically, if you get a classical history of stress urinary incontinence, no frequency, no urgency, and from the history, no voiding dysfunction, then yes, you can avoid urodynamics, but that only occurs in 3 to 5% of patients when taking history. Now, when you come on to the so-called, I would say, the evolution of surgery with TIPS, I think she highlighted the points in the first part of, the different types of surgery. One of the procedures in my early days that I was trained to do was obviously bladder neck needle suspension procedures. That was the STAMI and the RAS. It wasn't mentioned there, but obviously that's now been relegated to the museum. So in the 1990s, early 1990s, I was taught to do STAMIs and RAS, and I did them. The problem with that is that the 5-year success rate was a disaster, because the recurrence of stress incontinence was 95%. So based on that, that has now been completely removed. But in our early days, we did that. In the 1960s, the Birch corpus suspension came into vogue, done predominantly by gynecologists, because Birch, that's his name, is a gynecologist. And he designed the procedure. Then if you look at the urology guys, they lacked the pubo-urethral sling, which is called the Millen sling or the Aldrich sling, all right? And that is when you use your rectus sheath, strip off the rectus sheath. So urologists favored pubo-urethral slings, gynecologists, Birch corpus suspensions. So that became the gold standard in the 1980s. And I think I was privileged, I was trained to do that. And then from there, it became obviously the in thing about any form of surgery is that you want less invasiveness, better outcomes, less complications, shorter operation time, and quicker recovery. That would be any procedure when you're going forward and trying to modify the procedures. Same things happened with the stress urinary incontinence. So from the Birch, they went to the Birch corpus suspension. And that's the time I trained in Belgium, and they used to do it a lot. So I knew how to do it. I was trained on there in a way. And I remember when I first came to this department, that was 1996, after I was trained, The first birch corpus suspension I took 3 hours. And then I was called to Professor Mudley's office. No, I wasn't called there first. First, the head of urology phoned me. Professor Bereski told me, hey, Dr. Nkosi, what's wrong with your head of department? He's phoning in to find out why you're taking so long in theater. So I have to tell him that with any new procedure, it takes time. So then I was summoned to the office of Prof. Mudley, and I remember that. He told me, no, you're taking too long. So I said, listen, I come from endoscopy training, and the one thing they taught me, don't look at your watch, look at your outcome of the patient. So when you start these procedures, you can't go there and have a time that's very quick. As long as you're not complicating the patient, then it's fine. So I started doing birch corpus suspensions at King Edward in the 97s, that time. And I must say, I was shortening my time quite rapidly. And I could then do it in about 1 hour and 20 minutes. A beautiful birch corpus suspension laparoscopically. However, it was the same time the TBT got introduced. So the mid-urethral tapes, based on the integral theory, got introduced around about 96, 97. And I remember them coming down to Durban when they did the roadshow. And in fact, I was one of the first guys to do a TBT in this town. Myself and Prof. Beretsky and Mr. Free, the other urologist, we did it. And that's how I got into doing mid-urethral tapes. Now, if you look at the evolution of mid-urethral tape, what happened? As she mentioned, the first randomized controlled trial by Karen Ward and Paul Hilton was only published in 2004. This was introduced in the 1996-97. And by 2001, it was being done in large numbers worldwide without data. So everybody didn't have the data comparing it to that of the gold standard birch corpus suspension. But because it's industry driven, shorter, it showed all its benefits, as she mentioned, people decided to go to mid-urethral tape. Because you could do it in 15 minutes, as compared to doing a birch that took you 1.5 hours. So it got introduced. So we went to the retropubic route, classical TVT, tension-free vaginal tape, organic care. And then, as usual, they have a modification. So this is an down top technique when you do it. You go the needle this way. The urology guys modified it, and they introduced what was called SPARC, the suprapubic arc, which then came from the top down. Because for some reason, urology guys don't like operating vaginally. So they've introduced the SPARC, right, from the top down. And needless to say, there was very much more complications. The studies showed it, the bladder complications, the urethral complications. And 3 years after its introduction, the FDA banned it. So the SPARC is no more available. I was trained to do it. I did a few, but it's no more available. So that around about 2006, 2007 was kicked out, not available anymore. Now, as she rightfully mentioned, when you do your retropubic tape, which was the first TVT, just look at it logically. Gynecologists drove this. Secondly is that most gynecologists are not conversant with the Cape of Retzius. Most of them don't know how to do a cystoscopy, all right? And complications were arising. You got bladder perforations, and there were vascular injuries hitting the external ilia. Can you imagine that? Because once you deviate the needle slightly from the entrance point, the exit point is going to be increased because of the fulcrum. They had obturated injuries, bowel injuries, everything occurred. And then obviously, these complications, after it became notified, you can see in the literature, people then tried to modify to see how they could make it easier. That's where the transobturator route got introduced. Delorme was the first, and he was a French guy, and I remember going to his unit, and he was using the optic, and that was a type 3 mesh, which was really not on. And I was there, I remember that speaking to him, and I asked him, what's the evidence for this? And they said, well, there is no evidence to say that this is not a contraindication. 1 year later, they banned it. The FDA put a stop to it because it wasn't from the technique of this, it was from the mesh. That was a type 3 Optape mesh, stopped, banned. All right, so they come out from the outside in technique. Again, although they claimed you didn't require you do a cystoscopy, you're working below the cave of Retzius, they still hit the bladder, they still hit the urethra. So there were complications. Then they modified it now with the inside-out technique. That's the TVTO, classical. Again, I was fortunate. I went and I trained in Belgium again on that procedure. And I must say it made logic to me, because you can dissect right from the mid-urethra. And if you know how to use it and you take the safety precautions, you know how to basically guide the needle around the obturator, into the obturator foramen and around the pelvic bone. All right, and I've been doing that. And then they found, hey, listen, there were complications. Yeah, it was in the muscle. So if the patient developed infections in that muscle, it became a major problem. Because you really can't dissect the adductor longus. Otherwise, you're going to go in debride and you're going to cause defects and cosmetic problems. So they modified it to a shorter tape called the TVT Brevo. That's what I intend to use. So the tape perforates through the obturator membrane, but not into the muscle. And that's where it fixates. So that became the TVT Brevo. As usual, now they're looking for something that's less invasive. So they went on to the mini slings. And the first mini sling that came out was a TVT Secure. Again, I was fortunate. I was trained to use it. And I did it. And I recall, hey, my results were not good. But all my colleagues, they had very good results. So at one meeting, I asked them, tell me, where's the data? They reckon if they did it in this town, in Durban, I'm talking about. Some guys were doing it, and they claimed that if the patient didn't come to them after the surgery, they assumed the patient was well. So their endpoint was patient not returning, and they thought it was 100% correct. Worldwide, a problem arose. And then failure rates started. With the result, 2 years after its introduction, the FDA banned it. So again, I was trained to do the TVT Secure. I did a few, didn't get very good results. 2 years later, FDA kicked it out. So it's not available anymore. Same thing went with the bar adjust. Again, I was trained to use it. I did it. I had reasonable results, but bar backed out because of the mesh issues. So it wasn't a failure of the product. It's because of the litigation that was occurring from meshes. So if you look at mini slings, it has come in. There is no long-term data. As you say, it's class C, so it's not something that is recommended. Which then obviously brought us to this whole thing about this alert. The alert came on the public notification based on mesh for prolapse. But the media changed that, because when they started looking at mesh complications, and you're going to look at the mesh implants, if you looked at for incontinence, it was gone into the millions. But if you looked at prolapse, it wasn't that much. So per number, you may find that with the mid-urethral tapes, it's a significant number. But if you work it as a percentage, it is still low. But that's not what the media looks at. All they know, it was a complication of mesh inserted vagina. And that put some strain on the mid-urethral tapes. With the results, industry tried to back out of it, right? Doctors became a bit unhappy. And I think a lot of the societies worldwide started putting a stop or a pause to its usage. We in South Africa, we reviewed the data, and I drew up the opinion statement for Sauga in terms of it, and that's our so-called current. So we still do mid-urethral tapes. In many countries, it's still regarded as a gold standard, right? So that's where we lie with this. So just give you an overview. So I think what's important for you to realize is obviously what I would call the evolutionary changes that took place with the urethral tapes, where we lie at the moment. And based on that that opinion statement that was put there, I put it forward to patients, and if they're agreeable, I do it. I must say, my hands, touch wood, I didn't have any major complications. So we'll open up for discussion. Yep.
Thank you for the overview and the evolution. I think the first question I wanted to ask, when a person says, I was trained, what does the training entail? When you say, I went to Belgium, I was trained, I went to wherever, I was trained. What does it entail, this training? Because the way it's presented, the procedure doesn't sound that complicated, although obviously there's quite a bit of skill that's required, and that's why you find that people around town and everywhere else are going out there and they see one and they start doing another one in terms of that, and then there isn't any way that we can be able to say people were trained. So what does training actually entail of this tapes? Do you do it on the cadaver? do it on a model. That's what training entails, and then obviously you do one under supervision. What does it entail? Because I mean, if you ask me about our registers, how do we train them to do it? We operate with they see us operating, then they operate on our vision and our supervision. Eventually, they start doing the procedure themselves, and by the time they finish their 6-month stint, they can do hysterectomy with another registrar or whatever the story is. What does training entail of the story here? Because I've heard a lot of our graduates who've gone out there, and I don't remember them being trained to do this, but they're doing the procedure.
No, I think that's a very good question. It's something that also troubles us in terms of training, especially when you're having new procedures being introduced. The first thing is that I think if you look into urogynecology, and that's the way I look at it, the people that should only be doing these procedures are urogynecologists. That's number one. Or you're a high volume surgeon. So some guys can tell me, listen, man, you know, I'm not a urogynecologist, but I've been doing UroGyn for the last 15 or 20 years. So that individual is slightly different. It's just like oncology. If you take an oncologist now, and you take a guy who's done oncology but not certified for the last 15 or 20 years, that person is equally competent, or in fact more incompetent, because he's carries his experience. So the issue around training was basically to introduce you to the procedure, but not give you the license. That's the issue down here. So when industry got involved, much of the surgery became a recipe. They changed all these things into so-called kits, measures with a recipe with regard to how you do it. And I can tell you something, it doesn't work all the time. So the training issue, yes, you can go back, we go down there, we do cadaver dissections, we have talks, you insert it in cadavers, whatever it is, and you come back, and then does that give you a license? The company says, no, it doesn't give you a license, we only give you the exposure and the training. So that is the issue that we have. There is no such thing as to say, listen here, you are trained, and after you are trained, you're now certified and you're given license to do it. It's not like that. The question is that is why we say you must keep a registry, because tomorrow I get litigated. I can pick up my data and say, these are the things I've done over 8 years, which will hold weight in a court of law. I cannot go there and say, listen, I've seen YouTube and I've seen Dr. X operating, and I've only done 2 or 3. In a court of law, you take that guy on and he'll be in trouble. So the problem about training and when to do it is an issue not only pertaining to these procedures, it's to all procedures. Yeah.
You still have not answered. What does training entail when a person says, I went somewhere, I was trained? What did they do? Did they operate on the patient, or what did they do?
What you did, you were given formalized lectures.
Right.
You have cadaver dissections, and that's what we did. You put this, use these devices on cadavers, right? And you'll be given a certificate that you've attended the course. There is no certificate given that we're giving you license to do the procedure. Okay, that's all. So I would regard that as training.
In South Africa, are people trained on cadavers? Yeah. I mean, there's quite a lot of people that are doing this procedure.
No, they're not.
What are they trained on?
That's a problem. I mean, that's what I'm trying to explain to you. This whole training issue is a major problem. It's not only pertaining to UroGyn, it's to all procedures, whether it's laparoscopy as well. All you can do is, I've attended a workshop, I've participated in this, but it doesn't give you the license. That's where we sit.
So what would you? So
what I would recommend is not for them to do it. Simple as that. Unless you're a urogynecologist, you're a high volume surgeon, that you can show me that, listen, I'm not a urogynecologist, but I'm doing these procedures since inception. And we know guys, I know guys who are not urogyne guys, but they are guys who trained with me when I went abroad. And those guys are high volume surgeons. Yes, you can vouch for them. But don't come and tell me to vouch for one of the registrars here who exited this year and has done a procedure out there with a mid-urethral tape and ends up with a complication. That I can't vouch for. It's clear. That's why I drew the guidelines. You saw my guidelines.
Yeah, so the guidelines.
Those are national guidelines. It's going to be published. Okay?
So I'm just wondering, that's why I'm happy.
It's very simple.
That if Ramphal,
don't do it.
If Ramphal, no, let me finish my point. If Ramphal disappears from the scene here, in a Tekweni, in a Tekweni, because I'm hearing with the corridor talk that we have, you and I, that urologists are doing the procedure, they complicate, then they refer the patient to you.
Correct.
Then it worries me to say, if there's no Ramphal and then the patient complicates from these people that obviously landed on lectures and what have you not and all. What is going to happen to the patients in this town when there's no longer Uretrhal to sort out this kind of tape issues that are happening? Because
now the exact answer.
I'm not hearing Uretrhal saying I've trained 5 or 6 people.
No, I'm not going to train 5 or 6. She's my subspecialist. She's being trained and she'll take over. That's it. I don't want to pursue this discussion because I think we'd rather address other topics pertaining to the subject. This training issue, I'm clear about it. You know, I'm the president of Sauga and I made it clear. All right, even the guys down there when we have committee meetings. Not anybody, it's not for everybody. This procedure, if you're a gynecologist and you're exiting from your program today and you are doing this procedure and there's a complication, if you can't fulfill all those things that I wrote, then you're on your own. That is why we do guidelines and that's why we do positional statements. It's clear on the positional statement. You got to be conversant on how to do it, how to manage the complications, and you've got to keep your own registry. All right, let's see any other topics. Let's
if I may just come in. I just wanted to highlight that, so for the registrars, we bring these topics up. Obviously, it's a bit on the sub-spec area, but it doesn't mean, and I think we mentioned this on Wednesday, that they should not be conversant with the options that are there, their complications, and in some instances, even how to do theoretically. At a registrar level, some of these things may not be required of you to have done practically, but the theory thereof, you should be aware of, the side effects, the complications, the indications. I remember in my Part 2 exam, a whole essay of 50 marks was the discussion about the surgical approach of stress urinary incontinence. So you had to go through all of these birches and all the procedures and know them and how to do them. So it doesn't absolve the registrars from knowing the options, the indications, the complications. Yes, the do part is a sub-spec issue that Dr. Maisa is referring to. So yeah, I just wanted to make sure that people don't just think that, no, it's somebody who needs to go for training like Dr. Ramphal. That is a sub-spec issue. The procedures are supposed to be conversant to every gynecologist. A patient, when he comes, doesn't say you are a UroGyn and whatever. They come with the symptoms and you should be able to counsel and refer at the right level. Yeah, thanks.
No, I agree with you 100% what you rightly said. I mean, for registrars, they got to know these different procedures. They got to know when it's indicated. They got to know what the complications are. And theoretically, they should know how you manage them. That is it. I can ask you about a sacrocolpopexy. What's the principles of the procedure? I don't expect you to do it. So at a registrar level, you must be aware of it, because where you can get caught up, and this has happened, a patient will come with you, I got a vaginal discharge. Okay, very good. You assess the patient, meantime, you got a vaginal discharge from a mesh erosion. So you, as the gynecologist, must be able to pick that up. Hey, listen here, there's a problem here. That doesn't mean you must address the problem. Then you refer it to the relevant person, which will be a urogynecologist, somebody who has an interest with mesh erosions, etc. So you've got to know the subject. You've got to know about it, all right? And at the same time, we're not asking you to do the procedure. Any other, Sean?
So this directive came around 2017, so it's been about 7 years of now this in places like the UK where there's this new normal of not using mesh.
Yeah.
And potentially in our scenario, we have a situation where patients may say they don't want mesh.
Right.
Practically, what does that look like in terms of what you really offer these patients? What are they offering them in the UK and what are we really offering them?
I think it's a fair question, and I was given this talk in the Sauga meeting recently, where it was addressed with the current mesh issues. What are your choices? There's 3 choices. It's a birch corpus suspension, a pubo-urethral sling, and that of peri-urethral bulky. And depending on your patient profile, and again, from your urodynamic findings, then you make your choice. And obviously, what's best in your hands, and that you should share to the patient. I mean, look, I've done, and she's aware of it, we do birch corpus suspensions. I do it laparoscopically. So I can discuss it with the patient. Now, another person may not have that experience and may not even have experience with birch, But you can tell her, listen, yeah, you can do a birch, we can do a pubovaginal sling, and we can do periurethral bulking, but I'm not conversant, but Dr. X or so is conversant. If the patient is agreeable, refer that patient to that individual. Or if the patient said, okay, no, I want to be with you, doctor, I accept these two things, all right, I will. So it's an informed consent based on your experience, what's available in the literature. As long as the patient has been informed, then you can take a decision. But those are the three choices. Don't put in another mesh if there's a complication. Any other questions? Anybody online? I don't know, I haven't seen anyone online.
Yes, again.
Let's see, Dr. Maisa.
Who's doing the benches? The urologist or the gynecologist?
Sorry,
the benches, who's doing them? The urologist or the gynecologist?
I don't know, to be honest.
Best you can do it.
Let me be, yeah. The birch, remember a birch? That's his name. He started copper suspension in 1962. That was the first one done. He's a gynecologist.
Yeah.
So you would find that urology guys can do it if they're conversant in the cave of Retzius. So when you dissect, you get it down into the cave of Retzius, you got to understand the anatomical structure. What I found amazing is that I'm not going to be, I've seen some urology guys, even at Albert, when I started speaking to them about doing birch corpus suspension, they hadn't done one and they were not conversant with the cave of Retzius, yet they're urologists. So that takes me by surprise. So they trained me, to be honest. It was Professor Bretsky, when he took me in the arm and he showed me how to do birches. And I'll never forget, when we went in, we dissected the cave of Retzius, we made a hole in the bladder. And I put my finger in, I could pick up the bladder neck and I placed my sutures. And I thought, oh, these guys are terrible guys, they just make holes in bladders. Right? And as gynecologists, we are very afraid of making a hole. But as years progress, sometimes I just routinely do that. And just put in 2 or 3 sutures and that's it. So the placement of your sutures are critical at the bladder neck. But that is best done if you got your hand inside that bladder. However, laparoscopically, you can pick it up because you got magnification and you got light where I can pick up that area. So to be honest, when I look around, I'm looking at all the urology guys I know who are my colleagues. I don't know any one of them that can do a birch.
But if we were to follow the UK story and not do the slings,
what they are doing.
What's going to happen to us?
Yeah, what they are doing now is that, like similar what I did yesterday, I did a case of a pubovaginal sling. They're making a small incision, like a fancy incision. They're taking a piece of the rectus sheath, and then they're doing the rest of the procedure exactly, but not using the tape. So they're putting nylon sutures on both. They're bringing it up para-urethral into the cave of Retzius onto the anterior abdominal wall. And the support is a small piece of rectus sheath. That's what they're doing at the moment. It's a bit more invasive, but they find that with the litigation and the fact that they're not being supported by the councils and by the governance in the country, that's the only alternative they have. Any other questions? The registrars?
Intimidated by it.
Oh, you're intimidated. Here's your chance. So we did a pubovaginal sling yesterday. Okay, thank you very much, Dr. Nkosi. Your time there, you did well. Nobody else.
Thank you. Thank you.
Recording stopped.